Trust is the oxygen of public health, and lately, we're running low. We're Sciana Cohort 7, Ridul Agrawal, Raquel Correa, Judith Dios, Claudia Schad, and Andreas Welker, exploring how to rebuild trust in health communication. Today, we're joined by Tina Purnat, a pioneer of infodemic management at the WHO and a systems thinker with deep digital and data roots. We're asking, how do we move beyond fighting misinformation to designing health systems people actually trust?
Maybe a way of starting would be, how did you get to this problem as well? What did you find out while trying to approach this huge, immense topic of misinformation and mistrust?
I started working in this because it became part of my job. When I was working at WHO at the beginning of the pandemic, I was one of the staff that was reallocated to emergency response right at the beginning of the pandemic. So right in February, when it was no official declaration yet. And I was initially asked specifically because my background is health monitoring, health status marking, anything related to health data, how to communicate health data, engagement with data, translation of evidence into policy. And I have pretty strong digital background. So I was at the time working in the digital health and innovation department, but my background is I was asked at that time specifically to a very simple ask: how do we improve rapidly evidence that the communications at WHO was using in order to, as quickly as possible, identify questions, concerns, and different rumors that were circulating at the time, and how at least WHO for its own communications could use this better, but then also what is sort of like good practices and what we know from the evidence generation and tools related to monitoring that we could then also very quickly put together as recommendations to countries, because that's the role of WHO. So that's actually how we started. But very quickly, within 2 to 3 weeks, we set up a pipeline for a very rapid analysis of social media, how people were talking about and what they were expressing, what kind of questions, concerns, worries, and what else they were expressing online. And that actually does require, if you're doing this from like commercial point of view, what marketing companies do for businesses, it's a little bit different when you're trying to adapt this to public health. So because of my background, my team already at that time very rapidly pretty much innovated already, because we wanted reporting from anything related to social media to be a lot more directly actionable to the people, to the emergency operations, right? So it's not like, oh, let's just describe what people are talking about and then present one slide to the emergency team, and then emergency team needs to kind of figure out, well, okay, so what are we going to do with it? So we already at that time started innovating. But very soon, like within 2, 3, 4 weeks, it turned out that this area pretty huge to look at, because we really realized that from the point of view of immediate emergency response, absolutely needed practical tools, very practical evidence generation. But we very quickly also at the beginning of the pandemic figured out that the pandemic was not going to be like, it will not be a short outbreak. It's going to be like a massive total society event globally. And as soon as when you see that, then it also means that very early we started planning, well, what do we need to put in place so that we can support member states and we can actually start developing much more of a comprehensive way of looking at how does information environment impact not just like in the acute stage of an emergency, but literally what's the issue societally, politically, economically, etc., when it comes to information environment. And that's literally how my team was formed. At the beginning, it was just me and another person. And then later, my team grew a lot. We basically developed an area of work at WHO for emergencies called Infodemic management. But literally, when you're working in emergencies, literally 90% of the work, especially in this, has to happen before a lot of the things that we were doing literally came out of that. And that's what got me into the work. My background is information science. And so I already complemented the views of other colleagues, epidemiologists, social scientists, or people who traditionally work with behavioral science or communications colleagues. I definitely was advocating always that this is such an interdisciplinary and complex challenge that we're facing as far as promoting, like being able for us in public health to actually do our jobs. If our mandate is to deliver healthcare, it's harder. If our mandate is to protect public health, which means, you issue guidance and you are really counting on people to follow guidance, but there's a lot of anger or people are ignoring it, then there's a problem for us. And we need to actually do a little bit more reflection of what's actually happening. My views or my work has kind of expanded because even when I was at WHO, we were focused on acute emergency. Then we started broadening things out and we really started discussing, because WHO is a normative organization. We worked a lot on promotion of research agendas, understanding what it is, developmental practical tools for people and countries, developmental frameworks. What does it mean to, and what does this mean for competencies and things that we need to develop in health workers? But then the last 2 years, I've really broadened also the discussion, because the more I've been working with people who have worked either in misinformation for a long time or people that have worked in social behavior change, I am quite familiar with different approaches that have been tried in different countries. I was quite deeply involved with the vaccine demand promotion for COVID-19. Vaccines are an ultimate case currently on top of everyone's mind. I've started to realize that it's not necessarily just the fact that we have information environments different. There's political and economic structures that are creating different dynamics in information environment that are impacting how we are able to work and how people that we're serving are feeling, thinking, accessing information, and how this impacts their health behaviors. I've also realized that we ourselves in public health, in a very broad sense, public health system, right? So not only the healthcare delivery, but the whole public health, the whole package of mandates that we also have around public health, I've realized that not only are we always running behind the challenges that are related to digitization, digital transformation, people's changing relationship to information, people's changing relationship to how they make health decisions in general. We're really running behind, but it's also, we're not really that great. Our institutions, the systems that we work within, are really not that great at being reflexive, thinking about what is our role or where do we need to improve our systems. So I've changed from speaking very much practically about what we need to, because this was a part of my job also, tools development, strategy development, things like that. And of course, part of social listening, and we need to be accountable to people that we serve. But I've actually now adapted, depending on who I speak to, I'm speaking more and more about there's many things that health systems and healthcare are not meeting the needs. Many examples where we're not meeting the needs of people that we say that we serve. And people have questions and concerns that are not being addressed. And that definitely can contribute to erosion of trust. And a lot of times when we in public health speak about trust, there's still a lot of writing that comes out of political system. We kind of use the terms trust in institutions, trust in health workers, etc. But it all gets reduced down, well, if we just communicated better and if we just engaged better. That's not true anymore, because it comes off very paternalistic, and we don't teach and we don't talk in our workplaces enough that there's things that we need to change in the way that we approach how we design services, how we offer them, how we talk to, and how we work with people like patients, communities, when it comes to health. And we kind of still expect that people are going to trust health workers. But like if you see marketing industry, the trust in health information, they're still like, oh yeah, health workers are still the most trusted source of health information. Yes, but that's been eroding. And we shouldn't be really thinking about why it's eroding, and we should not just be saying, yes, let's just, work and continue working with health workers, when it's very clear that there's a bunch of issues that health workers are feeling in the responsibility that we give them, and their jobs are becoming harder. I mean, just healthcare, like nurses, doctors, people who work at clinical setting, the recent this week shooting at CDC, I mean, we see so much more violence, both digitally and physically, and health workforce for a long time. And this is not reflected in our discussions around misinformation or trust. It's kind of like detached on health workforce development. So my big point, having worked in policy globally, is that we need to turn around and stop being so separate in how we discuss these different topics of policy. And you actually need to flip the paradigm a little bit. And yes, one aspect is we need to be much better and much more responsive, much more equity centered when it comes to how we deliver, how we design, how we evaluate services. But on the other hand, we also need to find ways to really be a lot more adaptive as system in how we end up changing, adapting what we do, and how we recognize where our own structures that we put in place in public health or in health system, in our governance, or how we organize ourselves, that are actually creating this issue. So I very early on stopped saying that this is a problem of misinformation, because by the time that a misinformation narrative forms, it's a reflection of people's discontent, it's a reflection of people's identity, people's morals, values, that they feel a lot more attached or relating to a particular narrative compared to what we supposedly say is science-based and evidence-based claims, right? And the fact that people turn to something that is much more explainable, much more close to what is meaning to them, is actually a failure also on our part, not just in communication, but the fact that people form opinion through their experience, not just through what you tell people, but also through their experience. I stopped very early on saying that this is misinformation issue. It's much broader. I still talk very much about misinformation is when you're thinking specifically about harm, preventing harm and mitigating harm, because in public health, obviously, we also deal a lot with, while you're trying to deal with much more complex issues, at first you need to at least prevent and reduce harm that is being caused, which means you need to detect it and then find strategies on how to protect people who are being harmed. And in this case, it's both health workers and communities and patients, right? So that's the complexity part, but there's a big difference between what evidence says and what we see practically, where the gaps in practice are, versus how policymakers and, for example, in the global space, when you have philanthropies who are funding, for example, research or practical collaborations, or they might be funding civil society or NGOs that might be working, right? The language of people who have money and who are, of course, then influencing what should be done is still very much focused on misinformation. And they're not, and we're not recognizing that this is a systemic issue, and it's not the problem of the other people who are idiots who believe misinformation. It's actually our own systemic issue, and it's a failure also of us, because we're positioning ourselves as too paternalistic and too aloof, too like, yes, we're evidence-based and we're fighting a war against people who are anti-science. We are literally creating our own ideology instead of using everything that we know from social science and identity building, that we need to be the ones that we need to be crossing narratives, crossing bridges and connecting and understanding how we need to redesign things. So that's like a big issue for our public health systems, for our societies. And they're very complex, obviously, because it's issues that go beyond health, that are outside of the health system's mandate, Ministry of Health, for example, that you cannot just tackle everything. And that's why because it's so complex, there's a real need to always keep parsing and separating what is the issue? What is within our sphere of control right now and influence? What can we do now within the mandate that we are? And depending even of which part of the health system you work in, you're going to be thinking about different things. Like I have colleagues who are working in hospital, like in health systems and hospitals. They have very different needs for what needs to be done than if it's someone that's a policy analyst that it's at an Institute of Public Health or at a Ministry of Health at national or subnational level, right? They will have different concerns, which means that this is not something that can be very easily put in a box and say, now this is just a list of things we need to do. But depending on where you are in the system, you will be doing different things because your role and sphere of influence is different. In different countries, there's different issues like Europe versus US. US has a very cultural and very different narrative around this. But also in Europe, when you look at current health policy, because of the current concerns about security and disinformation influence and issues around budgets and how the budgets, for example, are being changed for health versus other parts of the government, the financing bit of services, all of that is influencing also that there's a huge inertia towards solutions that have to deal with disinformation and influencing. And we know that especially in health, you can't persuade people to enact a health behavior. It's not a matter of persuasion. Even people who are working in this space, they just attach health. Health is a part of a big health system, public health system, and it's something that we keep deciding every day throughout our lives. That's why we say health through the life course. Services are trying to be designed this way. Products, prevention is all trying to be designed this way. It's not just like climate change. It's not just like Russia's disinformation campaigns. And in policy and funding currently, a lot of policymakers, it's too complex for them. We haven't been able to, within our own professions, we haven't been successful in describing this. So because it's so complex, right? And because it's requires so many different perspectives, this is probably the hardest in how you talk about it. So I stopped trying to explain the universe to people. And I usually just ask and try to figure out, well, from what angle are you trying to address this? And the most successful thing that we can do is, yes, try to be as evidence-based, equity, gender sensitive that you can be, because there's much complexity there. And then just be aware that your angle is a complementary angle to someone else in some other part of health system or even some part of society that might have a different angle and they complement you as well. So what we need is being able to like recognize that this is a very distributed issue because this is an ecosystem or information ecosystems that impact us all, and that therefore, depending on what angle and point of view you end up taking, you will end up seeing and emphasizing a certain series of recommendations. What I've tried to do now is more and more emphasize the need for systems. So if we are building I'll give you an example. It's extremely popular to say that civil society or social justice movements are solution for a lot of these problems. But that's because in the US, there is no working public health system. And the way that they understand public health is through healthcare delivery. That's not how most of the world thinks about this. But solutions aren't only for communities to be resilient and to take care of, trusted information and support health behaviors. You can't scale that. You need systems that then support and wrap around what communities need. And this is, for example, more in the European way of thinking about what do you need? You need a balance between different sectors in society, and there is a role for government and health system to play in this, right? But if you think about this, it's really important to find ways and language and examples to, at least in my opinion, put a mirror to the health system and say, this is where you're this is where we're not meeting the needs of people. This is what's pushing people into this content, in disappointment, into fear, into not wanting to trust, not distrust. And that basically is linked very much into narratives, including misinformation, that end up reinforcing alternative ways of believing, alternative connections with other people who reinforce different things. So one is systems need to be thinking about this. And on the other hand, I speak very much about that this is a complex issue that we need to think from ecosystem point of view, which means that no, this is not something you will just create a Ministry of Information Integrity and you're going to solve this. Or you're not going to create a unit in a Ministries of Health and this is going to solve it. This requires a bit of public health 3.0, like redesigning how we work together and how we organize our system and what is our priority. So in international and global health speak, this is accountability to people that we say that we serve. Are we actually doing what we say and promise and we say that we're doing in as far as delivering services and products and things like that? So that's the two things that I've now come to. It's a complex thing, and we need to be really thinking about what makes us trustworthy as a system. So we need to recognize that we are a lot of times top down just telling people, but what the heck? Why aren't you trusting us? We are so science and evidence based. Everything is so methodological. Don't you trust us? And that's just not the way that the world works. And it's a little bit tone deaf. We don't listen. So that's my long answer.
So, how could we, as health professionals or leaders, health leaders, change it to a better conversation, better communication, so people start again trust health professionals?
It's both skills and really understand not just the skills to communicate, but what the current issues in modern times are. At the same time, we need to also be aware that what we do is important. For example, I work right now quite regularly with community health workers in New York City. New York City, 60% of people are born outside of the US. It's a city that's very international. And so the health services and the local Department of Health, they work with community health workers for outreach, for trying to connect people with different services. Community health workers, the biggest problem, so I ran some workshops, focus groups with them. The biggest problem that they say, and this is something you can hear anywhere in the world, they cannot compensate. The best outreach, the best communication cannot compensate for the fact that services are not available, that they are closed when people need them, that they become outdated, or that they run out of funding, and after 6 months after project is set up, it's gone. We need to improve communication, both the professional communication by the institution, but also of health workers. And at the same time, we absolutely need to find a way for heads of, so the policymakers, people who decide how much money we get and for what it's being spent in health, right? That they realize that the decisions that we make about delivery and the design of services, prevention programs, things like that, that how we decide to design and implement them is a complement to communication. Because no matter how good you communicate, you are still, and you cannot compensate, like you are then becoming a spokesperson for something that is not good. It's like, for example, I don't know, like, yes, communicating about a good pair of Nike shoes is great, but if Nike shoes were crap and they were hurting people's feet, it wouldn't matter how well the marketing campaign of Nike would go. And that's the part that we as consumers in our lives totally understand. We don't fully yet get it in public health. We need both. We need rethinking and empowering people who are designing, implementing programs and services, that they can be adaptive, that they can be much more responsive to what they hear from serving clients, communities, patients. And at the same time, we need to improve skills in communication. But here, for example, many communications trainings for health workers or public health professionals only talk about, you need to know exactly what your objective is, how you're going to say it, what your audience is. Great. But communications theory and practice have evolved the last 20 years. And now communications professionals talk about communicating gist, which basically means, like, imagine reading a headline in a newspaper. You create your own mental interpretation of what the full article is based on that, whatever the headline injects or implies to you. That's gist. That's like the essence of what they're trying to communicate to you. People nowadays literally don't read the articles anymore because it's too long, and they end up making opinions based on headlines, which means that, like, our skills in how we communicate, it's not just about tailoring to the audience. Yes, of course, it's really important, but we need to add additional tools and perspectives for people when they are being trained in health promotion, health education, health communication. For example, trainings in Europe. But I can tell you, internationally, when it comes to risk communication, community engagement, I know, because I had to review this and I was trying to introduce training into global trainings. If you compare current risk communication trainings globally to what they were 15 years ago, they are recycled materials from 15 years ago. Maybe they are slightly tweaked, but there's nothing new. And we are not advancing and complementing and adding to trainings in the name of being short, and it needs to be manageable. So, like, it's an issue when it also comes to training people, because if you see that there's, if you continue teaching people that tailoring and message and creating the best message is going to solve the problem, the information environment, message is not going to help you. During the pandemic, we used to say messages won't save us. But this is literally the only thing that we train people. You need to have a series of messages. So I kept asking, what's the perfect message for people to use COVID vaccine? What the heck? No, it's not the solution, right? So also in training, so the way that we try to do and improve this in WHO is through competency frameworks. Like, there is, for example, the Association for Public Health Education in Europe, ASPER. They did introduce, some of these things into the competencies for public health professionals. So things are kind of moving, but now you need to kind of translate it into practice. And that's where, still a big piece of work needs to happen.
Wow, there is just so much to unpack. Thank you for everything.
Tell me what your project is. Like, what are you trying to do? Because again, don't be too broad, because you can just lose yourself in it. Try to be as practical as possible.
We're still in the initial phase of exactly everything that you said. Is it governmental? Is it the way people are being educated? Is it a populational issue? Is it because we're too paternalistic or not? So we're still doing everything that you said. And I had two questions, because you touched upon so many things that are so relevant. So the first being the digital footprint of people that you mentioned in the beginning. What can we do to better track and to train healthcare professionals to be aware of this digital footprint? And then the second question would be, would you have any leads or any suggestions on books, papers, or people? Because you touched upon so many things: social theory, economical behavioral science. So I'm sure that you just have a lot of things that we will have to go through.
It also depends on exactly what you'd want to touch on. People express themselves online, not just on social media, but also in digital platforms a lot. Marketing industry knows this. And actually, the current digital platforms are designed around being able to capture all of that data about individuals and then turn that around into advertising, marketing of products, right? You basically try to get people to buy stuff. So the infrastructure is actually there. The challenge is that when you try to adapt this to public health, it's more complex than that. It's not one product and then you forget about it and you feel good about it. Like, it's just more complex. So when it comes to skills for analysis, there's different things, like people who do analysis of social media to inform a health program, or for example, people that do health communications. So people whose job it is to analyze social media, they need different kind of trainings and tools that would move them into the direction of being more systemic thinking, because it's easy to just repeat what marketing does for business, right? They have the skills, but maybe not always the background to translate into health context. So that was the challenge that I had with my team. I had public health background, some digital, but it's very difficult to find people who would have both. So in my team, when I was hiring, I didn't care about anyone having perfect combination of skills. It was all about cross-disciplinary collaboration. So that is one need. But then you have, for example, health workers, a nurse, a doctor who's working in a completely different part of health system, and they are much more, they will also tell you very much, they will develop a feeling what's happening with their patients, that something, some kind of a narrative, some type of discussion is happening in their town among the patients that they're serving. And they need, so what they need is not necessarily to learn how to analyze it. They need, one, people that, if someone is doing analysis of this, that they kind of give them a one page, this is happening and we see this. And they need one step further, resources or mini recommendations. This is how you potentially, you as a nurse, as a physiotherapist, as a doctor, this is how you can address it interpersonally with your patient, for example. So again, depending on where you are, analysis skills, absolutely. People that do institutional communication and social analysis, social media analysis for institutional communication, people that are working with adolescents normally have at least something about analysis of harms coming from digital spaces. So they analyze social media from that angle. You will have people who are analyzing social media from point of view of signals for diseases or for change in risk perception, things like that. So all of those, you can absolutely develop tools that are specific for different use cases that help them be more relevant, much more easily produce what they need to do, right? So that is from the analysis perspective. That's one. I mean, there is also all kinds of innovation that can happen here regarding this. So during the pandemic, we tried to motivate that type of thinking. So I co-wrote a manual called How to Build an Infodemic Insights Report in 6 Steps. Basically, it's something very practical for someone that for the first time ever was now said, their boss said, now you need to analyze social media and inform, what we do. So it was very much geared to people who felt like they didn't have all the skills, but how do you think about it? And a lot of it is not necessarily just digital. It's literally how do you ask the right questions and how do you end up synthesizing the information properly. The analysis of social media is very important, but my suggestion is if you're trying to be practical, figure out like 3, 4, 5 use cases that routinely might be happening in a country, or some NGOs that work with patient advocates. They have a different way of thinking about this. And then, position social media analysis around that. I think last year we published a paper from when I was still at WHO. We did a survey, global survey, of people who did social media analysis during the pandemic and later. And basically, everything that I told you from practical point of view, all of the gaps came out. People are not resourced enough, they're not trained enough, the tools are not really adapted to their languages. They are being asked to do just social media analysis, but the problem is like you have to be thinking about information. So all of that, like that's in a paper that I mentioned. And then depending on what you'd want to do, if you want just a primer or a summary, I can direct so that you get to see the complexity on how to try to simplify. I can send you things. Book, it's free. Infodemic Management in 21st Century. This is a collection of different authors that wrote very short chapters about different angles, different perspectives of how you should be thinking about this from different points of view. The challenge is, and this is what I often say, is that we need to think about what are the big shifts that are continuing to happen in the next 5 to 10 years, because we shouldn't continue be running behind the changes, right? So if we decide that we want to be presenting what's happening, we need to be thinking a little bit ahead. Like marketing industry knows exactly how generative AI and how the current development of digital is changing their industry. we should be asking the same thing, like just from point of view of digital communication. That's one slice. Why aren't we actually asking the same question and trying to see how we adapt? But our systems and the way that we organize public health actions, how we think about how to organize ourselves, what the problems are, they're not adapting because of the way that we're organized, the way that we think. So trying to make a revolution is, that's not how change happens. It has to be incremental. And so what do we propose practically now? And then how do we start educating people? This is actually a broader issue. So you always have two challenges. So I can collect some references and I can send things to you because it will just give you a perspective of different approaches, different angles on how to think about this. The most important thing is my suggestion would be that you click through my YouTube channel. Now it's pretty outdated, but I put all of the speakers and all of the lectures and all of the conferences that we ever organized at WHO on this, and it was very sectoral, extremely multidisciplinary discussions. It might be just click through and see if any headline is interesting to you, because literally you will again see different angles from adolescent health perspective, like all kinds of stuff, and it might be something that would be interesting to you. It's a big subject, so either you try to convince people it's big and you try to make an argument this is coming, or you take one slice and you think about what is the slice and what you can do within that. You cannot go wrong. Be kind to yourself, because you cannot solve this issue with one area of work alone, and it requires collaboration, new partnerships, new thinking, things like that.
It is priceless. Thank you so much, Tina. I know that you have another meeting, so I'm not sure if Lottie still has another question on my end. That's perfect.
So that's great. So you have a good. The only thing is, things change. So if you need to follow up, I'd be happy to meet later.
You have no hurry at all.
Perfect.
Thank
Bye.
you so
Thank you
much.
again.
Bye
Thank you.
bye, Tina. Bye
Bye.
bye.
Bye.